Preventing Opioid Harms in Older Adults, Relief Plus Video Training Series, Communicating for Opioid Safety and Pain Management, Part 1.
I'm Jim Shames. I'm a family practice physician. I'm also the health officer for Jackson County, Oregon. I'm board certified in family medicine as well as addiction medicine. I'm one of the founders of the Oregon Pain Guidance Group here in Southern Oregon. I do consulting for the Oregon Health Authority, and for the last 25 years, I've also done substance use treatment in a medication-assisted treatment program. You know, we do what we do, and it's hard to turn around and disbelieve what you were told to believe previously. But the truth of the matter is, the data is not there to support the use of chronic opioids for most chronic pain conditions. Get educated, and then understand that this is a safety issue. And once you understand that, it's much easier to have that conversation with your patient. Your patient is desperate. They're in pain. They may already be dependent on opioids. They know what it's like to not have them. And so having that compassionate, understanding conversation and guiding them to a safer place is hard, but it starts with understanding that it is not safe.
Redefining pain.
I'm Dennis Turk. I'm the John and Emma Bonica Chair and Professor of Anesthesiology and Pain Research at the University of Washington. The traditional way of thinking about pain by all of us, healthcare providers as well as the layperson, is that there's a symptom, and for every symptom there's a physical cause, and for every physical cause there is a treatment that will either alleviate the symptom or eliminate the symptom. So that's a traditional way, and it's not just for pain, it's for all kinds of medical conditions. That acute illness model is very simple and easy to understand, but when we talk about chronic illnesses, there often are a whole range of symptoms, for pain in particular. These symptoms, probably we can't identify the cause of those symptoms. In 86% of people who have back pain, there's no objective evidence of physical pathology. In people with fibromyalgia, a very common condition, that 98% of these people do not have any indication of any physical pathology. Migraine headache, there's no indication of the physical pathology. So that nice model that would simply say that there's a symptom, it's caused by something, and we fix it, doesn't hold up.
I'm Roger Chow. I'm a professor of medicine at Oregon Health and Science University. I'm a primary care doc. I also direct the Evidence-Based Practice Center at OHSU, and I was one of the lead authors on the 2016 CDC guideline on opioids for chronic pain. Our understanding of pain has changed over the last 10 or 20 years, where we understand now that pain is not a purely biological phenomenon. Rather, pain is greatly impacted by psychological and social factors. So people who are depressed or have anxiety or PTSD often have a much harder time coping with their pain and managing it, and they can be more functionally disabled, even though the pain score, for example, may be the same as somebody who doesn't have those factors going on. Work stress, family stress, all these other things can also impact how people manage and cope with their pain, and are actually better predictors of how severe someone's pain is and how long it's going to last than purely looking at an X-ray or a lab for most chronic pain conditions.
I'm Nora Stern. I'm a pain educator from Providence Health and Services in Oregon, and I have a background in physical therapy. And I think one of the things that's important for clinicians to realize is that with complex pain, your most important job is not to fix them with a pill, with a surgery, with the magic wand that you have. Your job is to be a coach and an advisor and guide the person who's suffering with pain in understanding how much they can do and how much power they have within themselves to change their pain.
We have to think about not only the physical symptoms, but we also have to be thinking about the impact that those symptoms have on people's lives, what their experiences have been in the past, and since you typically don't die from having chronic pain, you live with it for many years, and since we don't have a cure, then we have to start thinking about how is this impacting on people's lives, and as we think about trying to treat these people, we have to begin thinking about not just the symptom pain, but also quality of life, physical functioning, and what the person wants to be doing. So that's the more biopsychosocial model, which focuses on physical pathology, cognition, how we think about things, mood state, behavior, and the social context in which it occurs in.
My name is Joyce Schoberg, and I am an aging life care manager. My background's nursing, graduated from OHSU, and I own Aging Advisors. It's a local aging life care management company here in the Portland, Vancouver area. So there's many ways that pain can manifest in an older adult, and especially an older adult with cognition issues who isn't able to articulate. For some, it's just a rubbing of an arm or a repetitive motion that we haven't seen with that older adult before. Sometimes they're rubbing their hand or their neck, but they're not able to share or give us words to explain what's going on. We look at transfers, so when we're assessing someone, we find a way to ask, where are your pain medications? Where do you keep your medications? And then we watch as they get up from their chair and they walk through the home. And we look to see, is something bothering them? Is there a pain on their face? Are they wincing? Are they guarding a certain movement? Do they favor one side or the other? So we're trying to really look at all of the different ways in which they might not being able to articulate the pain, but be able to show us in other ways. We listen to their stories, because sometimes in their stories they're sharing ways in which they're not able to complete tasks in life or follow out wishes or goals that they've had.
My name is Michelle Maricos. I am a peer support specialist and person living with chronic pain. That providers need to understand that patients are very hard on themselves emotionally, that we are our worst critics, that we tell ourselves devastatingly hard things, that we tell ourselves that our pain will never end, that this is the worst pain ever. We tend to catastrophize, and that is really detrimental to our actual pain.
When it comes to chronic pain, one of the things we know is that the actual neural pathways for acute pain are different than for chronic pain. The pathways for chronic pain, when you say something really hurts, my back hurts, my knees hurt, it's very similar to the pathways that control our emotions. So when you are anxious, for example, it lights up similar parts of the brain that light up when people have chronic pain.
If a person comes in with persistent knee pain, we should be first understanding what their beliefs are about pain. Then we should be looking at all the different pieces of the puzzle. Are they active? What is their mood like? Are they sleeping? Because it's not that there isn't a relevant part to the puzzle that comes from tissue-related damage or nociceptive input, but you should be considering whether to choose to go down the road of testing findings and passive interventions first, or whether you should be looking at the more complex nature of the pain experience. And it's not a black and white kind of a thing, but we haven't gotten away from that process of pursuing only the physical experience of pain and stopping there and then being mystified about why they haven't gotten better. We haven't changed our language of how we explain pain to our patients and how we respond to them when their pain is persistent. And so inadvertently, we as care providers have been contributing to the sense of threat that our patients feel, because our language has been continuing to reinforce messages about danger and threat rather than reinforcing messages about safety and hope.
Pain education and communication.
My name is Laura Hiesacker. I'm a licensed clinical social worker. I work with Jackson Care Connect as a behavioral health innovation specialist, and I work with the Oregon Pain Guidance Group. what metaphor might make more sense to you. So maybe you're a musician, or maybe you're really into music. And so one metaphor might be, you've got your amplifier and you've got your guitar, and you're getting a crazy sound out of your guitar. And so you spend all this time sort of working on the guitar, when the reality is the problems with the amplifier. And so the analogy is that with centralized pain or with brain pain, that the amplifier is like the brain, right? And so and the guitar is the body. So when we start doing procedures and surgeries and all of these things that are sort of trying to get at the pain in the body, but we're not addressing what's happening in the brain and or the amplifier, we're not going to really, help things, right?
So the beauty of this new understanding of pain is that it allows us to open up a whole world of options with our patients for how they can change the way that they approach their lives and the way that they understand their pain, and leads them down a road of greater self-efficacy rather than a sense of complete disempowerment.
I think that we underestimate the value, especially of the provider, providing those preliminary steps around education.
Patient education is the key. It really is. Learning about how pain works throughout the body and having a good understanding about how that pain works really is a key component of how to disable the power that the pain can provide you.
If patients don't understand pain and we say, I think I want you to see a psychotherapist, they're going to say, whoa, my clinician, my doctor, my caregiver is telling me that the pain is all in my head. He doesn't believe my pain is real. If, however, your patient understands that stress and mood and pain are closely linked, that they understand that when the sympathetic nervous system turns the volume up, that it turns up the sense of threat, releases cortisol into the system, and engages the parts of the brain that are associated with fear in detecting that there's threat going on, and actually produces more pain, whoa, that completely changes the conversation.
So when our older adults have cognitive impairments, depending on where they are with their cognition or their level of impairment, there's definitely a lot of strategies to use, I think, when talking to people and approaching them. I love Teepa Snow's handshake because she reaches forward always from the front and shakes their hand, but then moves around and goes to the side. And so really we'll sit with someone while sharing stories with them and asking questions and getting information, but always approaching from the front, trying to be at eye level and looking at someone, and so that they can really see you as best as possible. And I think that's really helpful because we now know that many people with cognition issues also are having vision difficulties. And so, and other certainly visual impairments can be going on as well. So being closer or finding that place where it appears as if that person can see you best is so important too. That's really key as well, of asking them questions. If they are able to answer quickly, it's fabulous, but as their cognition becomes more impaired, they often need more time to answer your questions, and allowing them that time is so important. And as well, from the physician's standpoint, to really think through the questions that are most important, to pull and tease out from that client is as important as well. It's so important to engage them and to get to, warm up to that visit, but at the same point knowing you have limited time and how best to get the information out that's important.
Any time that cognition is an issue, you want to slow down your message, make it simpler, and simply say less, I think. So if the message is very simply, I want to make sure that we both understand together that the fact that you're having pain does not necessarily mean that you're harming yourself. You heard a long time ago that you had some degeneration in your knee or in your spine. I want you to know that that doesn't necessarily mean that you're going to have more or less pain. There's a lot of people who have things that show up on x-rays and they don't have any pain at all. So it may be part of the puzzle for you and it may not be. I do know that you're telling me you're moving less and less, and I'm concerned about that because I know that when people do less, actually there's some things that happen in the way that our pain is processed that makes pain worse. So I'd like to ask you if you're willing to think about going to physical therapy. They can help you with returning to activity. And I want you to think about one thing. You're sore but safe. You're going to have discomfort as you get back to moving, but it doesn't mean that you're harming yourself.
And so when a provider or the team can say, actually, a little bit of pain is not harmful, right? And that movement is actually, we use terms like motion is lotion, right? I mean, beginning to sort of build these things into their repertoire for patients to hear it's safe to move, it's good to move, even if you experience discomfort. Even breaking that down with a patient, there's pain and there's discomfort and there's, concern, and helping a patient sort of discern those different things, I think can be really valuable and so important if you're going to send your patient, say, to physical therapy. Right? You can lay the groundwork to say, hey, it might be uncomfortable. That's normal. That's actually good. But what you're saying to yourself is such an important piece of the process. So as your medical provider, I'm telling you, it's okay to move. It's good to move. You're going to feel a little bit of discomfort, but that's okay. You're safe, right? And to keep moving through it.
Defining and promoting success.
So tapering can be a challenging situation. This is something that most docs don't get any training in, and patients are often very distressed about it.
Hi, my name is Todd Korthus. I'm Associate Professor of Medicine at Oregon Health and Science University, and I'm also Chief of the Addiction Medicine section there. Some strategies that I use to talk with patients who are trying to come off of their prescription opioids that have clearly become a problem for them is, rather than me point out all of the ways this has become a problem for them, I try to ask questions that elicit responses where they tell me why it's a problem for them. So for example, instead of telling someone that their oxycodone use is a problem, I might rephrase that and ask, so what are the upsides of using oxycodone right now? How has it been a problem for you? And they may come back and say, well, it's only a problem when I don't get enough. And I said, well, has it caused any problems in terms of trying to get as much as you want? What does your partner think of this? Have you received any feedback from other people?
So it's important to, engage this in a thoughtful way, ideally in partnership with the patient. I'll often have conversations about patients about the risks of opioids and why we need to do this. Some patients will say, well, I haven't had a problem yet. They may be on a very high dose of opioids, but why do I need to be tapered? And I'll explain to them that it's like going down the highway at 90 miles an hour. Just because they haven't had an accident yet, they're still at risk, and I need to get them to a safer level. So they're at a safer speed, as the analogy would go. I will talk to the patient about our goals. So we're not necessarily going to get them off of opioids. In many patients, the goal is to get them down to a safer level. So the CDC threshold level now is 90 milligram morphine equivalents per day. So if possible, we often will try to get patients to that level to decrease the risk of overdose.
And so I like to think of it sort of like an iceberg. And at the tip of the iceberg is chronic pain. And under the tip of the iceberg is all of the other things that are potentially happening or could be happening with a patient that make the treatment of chronic pain or communication around chronic pain difficult or challenging. And so we liken it to like a litmus test, that when you are thinking, okay, there's something going on with this patient. Maybe they're on a combo of opioid and benzodiazepine, or maybe their morphine equivalency dose is higher than what is recommended, and you're concerned. Whatever the case may be, you've decided you're going to have a conversation with the patient about their care around chronic pain.
The problem with relying on pain scores, there's a few. One is that a lot of patients will report an improvement in pain scores, but would report no improvement in function, meaning that they are still unable to work, they're still unable to engage with their family and friends and do the things that they enjoy, which is probably not the ideal outcome. And if you actually talk to patients, I think there's an assumption that what patients want is for their pain to be gone. And I think that's true to some degree, but if you really talk to patients and ask, what would you like? Many of them will say something like, I want to have my life back, which is not really a pain-centered outcome. That's really a functional outcome.
It's very important to talk about pain in relationship to function, what they can do, rather than simply how much pain they're having. Because one of the things that gets us into the hole of thinking that we can't get people off of opioids is if all we're asking about is the intensity of their pain. Because people will continue to feel their pain at the same level of intensity, even though they're able to do more. And when people have focused on their pain experience with a lack of understanding of what pain is, they will tend to see it as a failure if they say that their pain is still a 7 out of 10, even though they're now able to go for a 10-minute walk, and a month before they couldn't get off the sofa. So there's now a tool that's being recommended by the CDC called the PEG. And the PEG stands for Pain, Enjoyment of Life, and General Function. And what that does is it allows us to rate the intensity of pain equally with enjoyment of life and what they're able to do in their lives. So that when we ask then about how they're doing, if they rate their pain at a 7, but they're able to now go for a 10-minute walk and they're able to play with their grandchildren, they get a better score, even if their pain level is the same.
So what we can expect for people living with chronic pain is that there's going to be days when their pain is going to be worse, right? And if you're actually helping a patient get their life back, there's even going to be more days where their pain's going to be worse, because maybe they're going to be, you might be working with them on the concept of pacing, right? And patients will say this all the time: I felt a little bit better, so I went and weeded my 5-acre garden plot, and then they're down for the next, 3 weeks, right? And so, but to work with the patient to say, as you begin to get your life back, as you begin to engage in the things that you are going to bring you joy, you will have times when your body's going to be hurting more. So helping a patient expect that that's going to happen, and giving them ideas about what they could do in response to that. And I talk a lot about what is the messaging that the patient is saying to themselves about the pain, right? So if you can help a patient anticipate that there will be flare-ups, that there will be these hard days, but they can create, opportunities where they can be more compassionate with themselves.
When you explain about those things, you can actually use props. So this is one of those props. This is called a difficult day basket. And so I filled this difficult day basket with some things that are really helpful for a pain flare. And when explaining about pain flares, it's really nice that providers explain what a pain flare is and that it's temporary, that we only use the difficult day basket for a 1 or 2 day span, and then we feel better and we continue on with our daily lives. So I have some games, we have some cards, we have a relaxation CD that is nice music and some relaxation techniques. We have some gift cards. Oh, I have a restaurant gift card, let's go out to lunch. Some photographs from some trips that is a nice reminder of, hey, I felt good those days, I'm gonna feel good again. We have a pain journal that's really nice to actually fill out for your patients to, the good memories and how they're feeling that day, so they can always look back on, hey, I was feeling so bad that day, but I'm feeling better this day. We have some nice relaxing teas, magazines, any kind of distraction of magazines. I have a travel magazine here. It's really nice to be able to plan trips when you're having a difficult day, to look forward to the future. Some colored pencils. It's nice to be able to get creative and use those colored pencils. And it's really nice to have this in the office to show patients of what they can put into their difficult day bags, that none of these were purchased. I just had these in my home and just was able to create my own difficult day bag, so it didn't cost me anything. So that was a nice kind of bonus too.
Another important component is learning about the role that pain plays in your life. Some people need to sort of reprogram how they feel about pain, learn ways to kind of get through the episode of pain. Other proven behavioral modalities are really very helpful. And then really you could say whatever works for you. Acupuncture could work. There's many safe alternative treatments that are out there. And if they provide support for you to manage your pain without using opioids, then I'd say go for it.
So it's important for the patient to understand that their expectation about being pain-free is probably not likely to be realistic. You should expect your pain to be reduced, but you should expect that you're going to have to continue to find ways to cope and adapt and live with the residual symptoms that you're going to have. That's a reality. Okay, you accept that, then we can begin to say what are the things you can begin to do. There are some things you can do on your own that are going to help you by pacing your activities, by engaging in relaxation activities. There are things that you can do to distract yourself.
I think that we need to remember that this is a slow process, that a taper may be a very slow process for somebody who's on opioids for a long period of time, and that success means improvement in function before it means reduction in pain. And it's very important for the patient to understand that and for their family to understand that. And I would say also that bringing the family into the conversation so that they can help with the communal process of promoting self-efficacy is very important as well.
Providers should know that they need to believe in their patients. Their patients are incredible individuals, and that their patients are capable of doing many things. Their patients are capable of living with chronic pain successfully. They just need the education, they need some tools and some tricks and some support.
Preventing opioid harms in older adults. Visit healthinsight.org/relief-plus for resources related to the topics discussed in this video. This material was prepared by Health Insight, the Medicare Quality Innovation Network - Quality Improvement Organization for Nevada, New Mexico, Oregon, and Utah, under contract with the Centers for Medicare and Medicaid Services, CMS, an agency of the U.S. Department of Health and Human Services. The contents presented do not necessarily reflect CMS policy. 11 SOW-OSSIP-18-04-OR